Thank you very much, and
Thank you.
thank you for the invitation to this wonderful country, wonderful city. I will just try to summarize all the things that we can use in keratoconus and we can put in the cornea in order to improve different aspects of keratoconus. Just remember that the keratoconus is more like a problem here, and also in the South America, not so much in the North Europe. That's why when we try to interpret papers, we have to think of where these patients are coming from. And the challenges for keratoconus mainly are, in the beginning, the high astigmatism, irregular astigmatism, and of course the reduction of uncorrected and best corrected distance visual acuity. Why do we need to avoid keratoplasty? Basically, rejection is one point, although DALK has very low rate of rejection. High astigmatism, the recurrency also is very important, and the vulnerability for trauma. And what can we use? Either rings, cares, and intrastromal keratoplasty. For the rings, we have to think about what are the benefits. Astigmatic reduction, high order aberration reduction, visual acuity improvement, and of course, a part of biomechanical stabilization. If you follow the rules are coming already from the era of Baraker and Blavaskaya, where they have the smaller the diameter, the greater the correction, the thicker the ring, the greater the correction. What we're using more for keratoconus, increase the volume at the periphery and decrease the volume at the center. These are the two aspects that you use. With the rings, we increase the volume in the periphery. There are a lot of nomograms, either depending on the high order aberration, the shape, the astigmatic, topographic, and coma axis. We would love to have them coincide, and that will have even a better effect on the rings. But if they don't coincide, then somehow the effect is not as good. And also, we can use different morphological keratoconic patients. And basically, I will just show you that if the Zernike polynomials, or let's say the shape of the cone, is more symmetric, then you use a symmetric ring. If the shape is asymmetric, then it's better to use an asymmetric ring. And that is the rule that we follow. And these are the stages that usually rings go better. If it's thinner than 55 diopters, thicker pachymetry than 450, and the symmetrics. Usually these are the patients that go better with rings. What are the problems with rings? Extrusion, melting, and corneal infection, and I'm sure that most of you are aware of all these problems. So long-term positive refractive visual results can show that the rings are actually doing a lot of benefit in the keratoconic patients. And we would like to have softer biosynthetic materials that will mimic the refractive index of the cornea, and it will help us put the ring even closer to the center. Now we go back to CARES. We have at the moment 3 or another one 4 companies which are manufacturing CARES. With CARES, we have the advantage of putting and adding tissue more anteriorly than with rings in a difficult optical zone. What we have as a follow-up, we have elevation of the mid-periphery, epithelial hyperplasia, stretching and stressing redistribution. And of course, an induction of posterior coma, which will help to compensate for the anterior coma. So we have more superficial implantation. We do have extrusion, so the no extrusion is a bit of a question mark. You can use it in thinner corneas, and you can use them if you extract the ring, you can put them in the place of the ring. So it's biocompatible, similar refractive index, and you can customize it perhaps a bit more than the ring. There are special considerations because the more you add, the more you put in tissue, it doesn't have exactly the same effect as the PMMA. It is working, it is stretching, it is stuffing, but it doesn't have the PMMA effect that we have with the rings. And this is obviously because the more tissue you put in, finally it will be not as thick as the tissue that you measure in the beginning. And this is the Poisson ratio to make you understand exactly what happens. Corneal flattening happens through biophysics. As you can understand, the rigid one will flatten in a more programmed way rather than the softer one that we don't exactly know how would be the effect. And these are the challenges. The other challenge is that we have different nomograms. Most of the nomograms came up from the rings. We don't have at the moment reliable nomograms for the cares. This is another challenge. Shadi probably will help us with that. The Istanbul protocol, you can see here on the top, this is the anterior tangential map and the elevation map. So if you follow carefully the Istanbul protocol, you will see, like in case 3, that you don't do anything on the cone. So what you need to do is use the elevation maps to embrace the cone. So this is another element. Don't use the anterior curvature, but the elevation map will be better. And also we have different protocols and different procedures for the same material, so we still haven't found exactly the best place to as regarding the depth and the length to put them. So you can see that in most protocols you can see the insertions are different. Of course, we have new complications like neovascularization and lipid keratopathy. So let's have a quick head-to-head comparison between the two regarding the cares and the best corrected, uncorrected visual acuity of the eye of the rings. Rings actually do a little bit better on regarding the best corrected visual acuity, the Kmax, and the spherical equivalent. And in this one specifically, we're talking about the Kera ring. And this is a study that Olivier Persant presented years ago. Long-term stability, we know the stability of the rings. There is still an element of question mark with the caries. And the stability of the host tissue is also an important issue on the caries that we have to take care. So I'm just trying to summarize that and go into the next technical limitations. I think there are more on the case, and you can see on a video here in the case. The preparation takes a little bit longer. With the ring, things I think much easier on implanting. So the limitations: tissue quality, availability, tissue handling issues, and shape thickness are not as predictable as expected postoperatively. What if we put a donor cornea in the receiving eye in a pocket? This is the intrastromal lenticule, or the like. For the like, you have to consider when you put an implant, you consider the scarring, the downgrowth of cellular population in the initial period, and also the slower nerve regeneration, which will have fact in all the tearing and the sensation, and of course also the nutrition of the tissues that you're adding. And there's an extra problem, of course, is refractive change and rejection. These are most of the problems that we had with adding a smile lenticule inside the cornea of keratoconus. Of course, you have some other possibilities like customizing that. With effective light, we can improve it, things with cross-linking as well. So there are good things and bad things with the like, and either with the standard like or with a small lenticule intrastromal like. The donor tissue comes usually from the smile or cadaver eyes, or we can use recently, if you can see here, we have some cases where vision improved, some cases that vision didn't improve. And recently came this concept of decellularization. So what we do that, you use enzymes or chemical detergents or hypertonic solutions or some physical decellularization in order to get tissue from pig eyes and decellularize it and use it instead of the smile. And these are the ways to do it. In this way, you have to balance between intracellular matrix significant loss and the antigen that you introduce And that is our very first cases that we have been shown when I have a visit in China. That's where most of the decellularized tissues came from. And of course use them. And then came another product that Professor Messer just showed, which is a Xenia, again porcine product. Professor Messer showed the two models, one Xenia 1 and Xenia 4. I've used the Xenia 4. They were the best results as a matter of improving the refractive index and so improving the refraction. Not so much the stability, but also we had cases that we have to take the Xenia out before of melting. So to try to summarize how we will see patients with keratoconus. First, measure the comma. If the comma is between or less than 1 diopter, I think the protocols that we use with PRK cross-linking, either topographic, tomographic, whatever way you want it, are working really fine. Just stick with these protocols. When are we using rings? When we have thinner corneas, higher astigmatism, higher comma than 1 diopter, and an advantage should be to have a symmetric phenotype, so that will help the ring work better. Symmetric phenotypes like nipple cone, bow tie. When we're using CARs? When the cornea is thinner and still you have high astigmatism, comma, more than 1 diopter, an asymmetric phenotype, and in cases that you have a low risk for infection or extrusion. When to use intrastromal keratoplasty, either in the form of taking a piece of a lenticule from smile or even Xenia. When they have even thinner cornea, 370 or even less, cases which otherwise you will do dark, in high myopia, in advanced keratoconic cases, and before commencing keratoplasty, just as a measure to stop, to halt the procedure. So this is just to help you navigate and try to get a roadmap of irregular astigmatism and what to use. So the take-home message is rings are best for moderate keratoconus. CARES is an emerging alternative for thinner corneas. Intrastromal grafts can help you reshape the cornea, but usually are just one measurement before the DALC. Always combine them with cross-linking. And the phenotype selection is critical for your judgment of what to use. And for that, I would like to remind you that we have our keratoconus, World Keratoconus Congress in Florence in April, after the huge success of Athens and Dubai. Thank you very much.